Okay, so one question that I got from a few of you was on the last quiz. There was a question about obstruction, stone obstruction in the common bowel, right? And on the question I said, right, is that cholelithiasis? You know, true or false? And a lot of people answered true. They said, well, I thought that was correct. If you remember, if you go back and look at the terms for common bile duct is actually called docholithiasis, right? So it's kind of a tricky one. So I kind of give you guys a bit of a curveball. But anyway, and so for those of you that emailed me, and I can actually post that too online. There was a crazy cool YouTube link that I put to kind of further explain that. I thought it was actually really well done. So anyway, okay, let's talk about really quickly, just kind of breeze through, just in very brief review, the endocrine system. But before we do that, let's actually just kind of go over split. There we go. Let's actually just kind of go over some terms that we've learned so far. So let's see. I know I feel like I asked you guys this question all the time, but okay. So if let's say that I have maybe I've got a hemothorax, I've got blood collecting, obviously, in around my lung after a trauma. What procedure will they do to drain the blood, right, from the area? What will they do? What's that called? They're going to aspirate fluid from the chest cavity itself. What do we call that? Who remembers? I know you know it. All right, we'll start small. So what's the combining form for chest? Okay, or okay. So if we're draining fluid off of something, what are we doing? So what would that be, Dave? Bingo. Okay, nice job. Okay. All right, way to go. Okay, so for example, let's actually move over to the heart. So if I am having, let's just say that I'm having a coronary angioplasty, right? That's a weird one. What's being done there? Who remembers? First of all, who can tell me the difference between the coronary heart vasculature and the heart muscle itself? What's the difference? Who remembers? So the coronary arteries do what? Okay. Okay. Yeah, they do. Technically, they bring blood away from the aorta to the heart muscle itself. So they actually provide the blood supply and the oxygen to the heart muscle itself. So when we have someone who's having a heart attack, right, they're having a myocardial infarction. So what there is there's actually a blockage of the coronary artery, right? So if I'm doing an angioplasty, what am I doing? Okay. Oh, sorry, I'm so sorry.
You're repairing?
I am. Yeah. Surgical repair of the vessel, right? Angio vessel, right? And so the way that they do that, generally speaking, is they'll do a balloon angioplasty. They'll put a balloon right into the vessel wall. They'll actually inflate it. And if the plaque is not hardened, it'll actually push the plaque to the outer wall of the vessel and actually kind of expand the lumen, the opening. Okay, nice job. Okay. All right, friends. Endocrine system. Here we go. We're just going to go over a brief overview on this as well. Okay. Man. Okay, so obviously, we know, those of us that have taken AP know that the endocrine system is made up of endocrine cells, and generally speaking, right, those endocrine cells function, right, via secretion of hormones, right, that ultimately are meant to have an effect on target tissues. Okay, and those can either be close to the site of secretion or further away from the site of secretion. But the main job of the endocrine system is to maintain homeostasis. Okay, that really is its main job. All right, so here is kind of a schematic drawing of kind of a very basic negative feedback loop that takes place. And this is obviously one that all of us I'm sure are very familiar with. So we go and we eat lots of food, like I did over the past few days, right? And as we do so, blood glucose tends to rise, right? And when it rises, right, that actually sends essentially a signal, right, to the pancreas to secrete insulin. And when the pancreas secretes insulin, it essentially allows the glucose to enter the cell, essentially converted into ATP, and then, obviously then gives the cell energy and blood glucose levels drop because of that, okay? Alternatively, when blood glucose levels fall, okay, we know that then that glucagon is secreted from the pancreas, breaks down glycogen from the liver, and produces glucose. That raises our blood glucose. Okay, so those are examples of how these feedback loops maintain homeostasis for us. Okay, I love this book. Obviously, okay, we have many different endocrine organs here that you can see, and believe it or not, the vast majority of them actually begin in the hypothalamus of the brain, right? And actually have a direct relationship, not only to the anterior and posterior pituitary, but also to the effector organs as well. And we'll talk, so here's the kind of the schematic of that. But here is just some specifics, right? So obviously the hypothalamus produces an inhibitory or a releasing hormone, right? That actually has a direct effect and targets the pituitary gland. Right, so the anterior pituitary is essentially the workhorse, right, of the system. It has basically 7 different hormones that it produces that target different tissues. Everything from FSH to luteinizing hormone, TSH, okay, ACTH and growth hormone, right, and then prolactin as well. The posterior pituitary is obviously a little bit more limited in what it actually secretes. That's oxytocin and ADH, right? Our pineal gland is responsible for secretion of melatonin. Thyroid gland is thyroxine, right? And then parathyroid gland, obviously, calcium levels, bone density, osteoporosis. When we are working someone up for osteoporosis or osteopenia, we are essentially concerned potentially about the activity of the parathyroid gland. Okay, and then we have the adrenals that sit atop the kidneys. Okay, and these are all unmittal. Okay, so here is obviously just kind of a schematic, a drawing of obviously the hypothalamus within the anterior and posterior lobe of the pituitary and the different target glands that they have an effect on. But how exactly does this happen? I mean, we know that this happens, but the one thing that we need to be able to do is essentially try to describe the relationship anatomically. So we have actually another name for the pituitary, right, is the hypophysis, the hypophysis, and we have this hypophyseal portal, right? This vascular portal that actually essentially carries the hormones essentially produced by the hypothalamus into the pituitary, right? In the anterior posterior pituitary, and that is essentially how this anatomical relationship is essentially maintained, right? So obviously there are a lot of different functions, obviously of the anterior and the posterior pituitary, but the bottom line is that if not for the portal system, this physiologic relationship would not exist because the structure would not obviously be there for transportation of those hormones. Okay, let's talk about the thyroid really fast. Okay, thyroid, as we know, right, is the gland in the neck, and its main job is to produce a hormone called thyroxine. So thyroxine is very important in the essentially production and storage of iodine, right? And we have, and it's really interesting. So the school of thought, we talk about thyroid disease is actually starting to change. We used to diagnose people as having hyperthyroid or hypothyroid. However, right, new evidence is actually emerging that until we do further testing, actually the appropriate term to use is thyrotoxicosis, as opposed to hyperthyroid or hypothyroidism, right? And that essentially refers to a dysregulation of the secretion of thyroxine and thyroid hormone, right? Until that can be further worked up. So there's actually a big push to change the way that we actually categorize this as thyrotoxicosis until further testing is actually warranted or performed rather. And then obviously we have the adrenals. Obviously in the medulla, they regulate our fight and flight. Also responsible for producing sex hormones as well, right? Glucocorticoids and many, many different types of hormones. Really interesting, actually. So there is actually obviously, as I'm sure you guys all know, a very close relationship between the adrenal glands and metabolism, right? So we can actually have a condition that can actually kind of mimic some symptoms of diabetes, and that's called hyperaldosteronism, right? Because what can happen there is we can actually secrete these excessive amounts of aldosterone that actually raise blood glucose levels and can actually mimic signs of diabetes. Admittedly, this is a lot more rare in the population if we were to kind of weigh that against the kind of the presence of diabetes. Hyperaldosteronism is definitely something that could be on a differential list, but particularly people that are thin and generally active, but still have hyperglycemia, hyperaldosteronism could be something to consider. Okay, guys, word parts. Okay, I'm not going to read these off to you guys. It's pretty self-explanatory, but a couple things that are definitely worth mentioning. Okay, really important, particularly in the setting of thyroid disorders. Oftentimes we see this condition known as acromegaly. Okay, so if you've ever seen someone that has acromegaly, they typically have, very, very large skeletal structures. One of the things that you'll often notice with these people is that they will have a very, very large and widened mandible, typically very, very large. And so that is a form of acromegaly, right? Someone who has, for example, maybe diabetes, and that's uncontrolled and or potentially hyperaldosteronism would have what's called polydipsia. So we see the combining form here, dipso, which means thirst, right? And so someone, yeah.
So how would, for example, if you're also considering like a patient if like Marfan Syndrome, possibility,
absolutely.
What would you say would be like besides like the mandible? When you say like large body structures are like more like heavily built than like usually than someone with like Marfan's or more like kind of like longer and like skinnier.
So is your question kind of what would differentiate?
Yeah. Like
okay. Yeah. So ultimately, people that have that's actually really good. It's a good question. So people that actually have like thyrotoxicosis and or acromegaly because of a thyroid condition, generally speaking, will have those enlarged facial features. But the one thing that you'll notice with these people, that generally speaking, people with Marfan's won't have is muscle tone, right? These people generally will not be as fit looking, right? The other differentiating factor, particularly on your clinical exam, is going to be the fact that their heart sounds are going to be relatively normal and benign, right? And that's kind of another discussion. But the cardiac exam is going to be different, right? And the other thing, if you remember, because when we talked about this in Tech 1, very often you're going to see, obviously, your problems with obviously connective tissue extensibility, and you're going to see, obviously, generally speaking, Bacon criteria. They're also going to be generally positive. Okay, cool. All right, other things to know, right? Acidosis. Okay, acromegaly, we talked about that. Addison's disease, cretinism, Cushing's syndrome. These are all endocrine disorders. I don't even really understand the physiology of all of these and some of the differentiating factors because it's pretty complex. Diabetes. Okay, there's diabetes mellitus and diabetes insipidus. Gigantism, goiter. And all of you, who's ever seen a goiter, by the way, on someone? Yeah, very interesting. So essentially what happens with goiter, right, is that the thyroid cells themselves become enlarged and kind of lose their inability to excrete thyroxine, right? And so ultimately, though, generally speaking, those typically go untreated unless they start to obstruct breathing, right? If someone starts to have problems breathing, generally speaking, that'll be treated surgically, and or maybe they'll attempt some other type of medication to get that to kind of subside. Okay. Yeah. So ultimately, acromegaly, it essentially alters the activity of osteoblasts and osteoclasts, when, and that actually also has to do with activity with the alteration of parathyroid function as well. And it actually alters bone size and shape based on how it essentially affects the production of calcium and bone growth factor. I mean, the physiology of it, I don't even understand all of it, to be honest, but it's really very interesting. So, all right. I know that was kind of a quick flyby, guys. But like I said, you won't be quizzed on that, but you can just kind of know some of these terms, obviously, for the final. All right, let me pull up our next one. We'll go through this. How you guys doing on the Zoom? Everybody's good? All right. Wonderful times. More fun. Whoops. Oh, all right, cool. Here we go, friends. Obviously going through like the hardest systems on the last day of class. Sounds like a great plan. Okay. All right. Okay, the nervous system and special sense organs, guys. So obviously all of us that, how many of you guys, I'm pretty much all of you have taken under like AMP here, like I said, right? Except for maybe a couple. Okay. Because I know sometimes we have like, maybe sophomores and things like that in class that haven't had it yet. Okay, so the nervous system, right? So when we talk about the nervous system, we're talking about brain, spinal cord, peripheral nerves, and special sense organs, right? Extremely complex, really known as the driver of the human body. Okay, what the nervous system does, the rest of the body, the rest of the body follows, right? And so ultimately, we have two essentially kind of types of nervous system. We have the central nervous system, which is the brain and spinal cord, right? And then we have the peripheral nervous system, okay? And that includes all the nerves exiting the brain and spinal cord, including the cranial nerves, right? In certain locations, obviously, we have large networks of nerves that actually come off of anatomical structures known as plexuses, right? For those of you that have had any of my athletic training courses, it's the worst nightmare for all my students. Brachial plexus, it's horrific, but it's okay. It's fine. Yeah, it's pretty nasty as far as just the level of detail. Okay, but ultimately, right? What you guys need to know, okay, peripheral nervous system is all the nerves coming off the brain and spinal cord, right? Central is brain and spinal cord. All right. All right. Ultimately, right? The way that we define the nervous system too is anything that's under conscious control, okay, particularly being muscles, right, sensation. That's my somatic nervous system. Okay, that which is under unconscious control is my autonomic system. Now, ultimately, too, there is actually another anatomically, they've actually identified another branch of the nervous system known as the enteric nervous system as well, that innervates the abdominal viscera, obviously colon, stomach, and those types of things. And we'll talk about that too in a minute. But what about the somatic nervous system, right? So ultimately, it's going to innervate muscles, okay, fascia, and the skin. So this is super interesting, right? Generally speaking, when we talk about the organization of the system, right, we're going to refer to this in levels. Okay, what in the world are you talking about levels? Like what? So ultimately, what a level is, okay, every peripheral nerve that we have branches off of a corresponding nerve level at the spine, right? So ultimately, everything essentially from our first cervical nerve here, C1, all the way through S1, right down to the bottom. So all of these nerves have a corresponding root. Now there are situations like in the brachial plexus and in the lumbar plexus where they cross over between cords and trunks, and so there's actually some anatomical. There's a little bit of anatomical wiggle room, so to speak, in describing which level we're actually talking about, but that's not for this class. Okay, so though, okay, we also talk about myotomes, and guys on the Zoom, you guys can see my screen, yeah? You guys are seeing what I'm sharing?
Yes.
Perfect, thank you. All right. So obviously we know dermatomes are describing the innervation of skin and fascia, right? Whereas myotomes are describing muscular movements, right? So if I take my arms and I go like this, which myotome is that, Josh? Bingo, got him. Okay, C5, okay? If I extend my thumb, that's my C7 myotome. Okay, all of those are coming from, okay, either the C5 nerve root in the neck or the C7 nerve root in the neck. All right, so that's essentially how that works. You guys are going to learn those. And PT school, med school, PA school, wherever, nursing school, wherever you choose to continue with your life. Okay, excuse me. By the way, when you watch these lectures later, I think I don't know how that I was entirely coherent when I was actually recording them. So there may be some words that sneak in there that probably don't make a lot of sense. There might be another language or something that pops in there every once in a while. Okay, so the autonomic nervous system, right? So this is going to regulate the response of the viscera. So the abdominal viscera, okay, my smooth muscle, cardiac muscle to an extent, right? And tissue and glands. Golly. Okay, so clearly, oh, hello. Clearly, right? My autonomic nervous system is further divided into sympathetic and parasympathetic divisions. We gave the illustration last time, right, when we talked about going and working out, and not necessarily feeling like you have to go to the bathroom or work out, right? Because obviously increased sympathetic, input within the somatic nervous system down regulates your abdominal viscera, and then when you actually calm down abdominal contents, then obviously that parasympathetic stimulation rises, abdominal contents fall in the colon, and you feel like you have to go to the bathroom, right? So anything that's parasympathetic, right, is going to kind of down regulate my skeletal muscle, kind of make you relax a little bit, kind of chill out, right? And then obviously it's going to increase my smooth muscle activity. It's going to upregulate it, okay? However, if I have increased sympathetic activity, what that's going to do is just going to upregulate my skeletal muscle, right? My somatic system, and it's going to downregulate my abdominal viscera and smooth muscle and some glandular activity, okay? And we talked about too, and this is actually really interesting. We talked about too how some anatomists have actually kind of further subdivided out. Whoops. All right, cool. So 1 second, let me fix that. That's weird. All right. Try that again. Oh. Okay. What about now? Is that better? Perfect. Awesome. Cool. Okay. So some anatomists have actually gone on to further describe kind of what they're calling the separate division of the autonomic nervous system, and they're calling it the enteric system, right? And so ultimately, with increased parasympathetic activity, as we've already talked about, that enteric system, so to speak, is downregulated, right? Anyway, just fun fact. Okay, all right, nerves. Gotta love those nerves. Okay, so here's the deal. There is actually really, and anatomists and physiologists have actually debated about this for a long time. There is such a ridiculously amazing interplay, right, between the endocrine system and the nervous system that for a while they actually almost did not subdivide these into separate systems. So we can actually see kind of the obviously the dendritic connection between obviously one cell body and another. Clearly, if it's dendritic, it means they don't touch, right, and they function by way of neurotransmitters. So we have two different types of neurons. Okay, obviously that impulse is propagated, starts the dendrite to the cell body, and then down the axon, right, to the synapse. But we have two different types of neurons. We have the unmyelinated neuron and the myelinated neuron. Which one of those do you think sends an impulse more quickly, myelinated or not? Who says? Yeah, absolutely right. We have this awesome French dude that actually named those little, obviously those Schwann cells there. The notoform, yeah, great guy. I don't really know him, but I had a professor that did that, and it really cemented that for me in my head. Super fun. Okay. Obviously, right, for those of you, like, we have these really slow non-myelinated fibers called C fibers, right? And C fibers are actually notorious for activity and pain responses, okay? So you guys will learn that. Obviously, when looking at the structure essentially of a reflex, right, and or of the nervous system, we break this down clearly into three very simple components, right? So we have first and foremost a stimulus that's picked up by a receptor in the periphery, travels via an afferent nerve to the spinal cord. Early morning practice. No, okay, just checking. Okay, hits an inner neuron right at the spinal cord or brain, right, and then out through the efferent neuron towards a muscle gland or nerve. Anyway, I'm glad you're a good sport, Jay. All right, cool deal. The brain, okay, the brain. Here we go, right? So obviously the cerebrum itself is actually here, but that's divided into different lobes, okay? We have the frontal lobe, and the prefrontal cortex here, which is, you know, part of my brain that doesn't work effectively. Anyway, that was a joke for those of you that don't need. But okay, and so we have the precingulate posterior gyri here, obviously the parietal lobe, the occipital lobe back here, which obviously kind of governs vision, right? Now, who can tell me, because they didn't label this picture, what's that? What is cerebellum? What's it do? Generally, it regulates what? Balance. Okay. Yeah, and we're going to talk about that in a second too. So there, yeah, there's central control of balance in the cerebellum. There's also peripheral control through the anterior as well. And obviously, we have the pons midbrain, brainstem, and spinal cord as well. Now, here's the deal, right? This is why, okay, the anatomical landscape here, this is often why high cervical spine injuries, kind of C1, C2 here, are often either produce paraplegia and or death, or quadriplegia and or death, right? Because they are so high right up the spinal cord that if you have a fracture at C1 or C2, it can actually directly impinge on the pons, cerebellum, brainstem, and actually shut down your breathing. Right. So really important. Little clinical pearl there for you later. All right, the eye. Okay, not one of my favorite structures, but we'll do the best we can. So we have the fibrous layer, right, which is the cornea and the sclera. Clearly, you can get an abrasion of the cornea. That's known as a corneal abrasion. They're very painful. If anyone's ever had one, they're pretty bad. They're kind of horrible. And then we have the sclera. So the sclera generally is the white part of the eye. If any of you have ever seen anyone who has jaundice, what you'll notice about these people, right, is that their membranes and their sclera of the eye will actually be yellow, right? They'll actually kind of start to yellow a little bit, right? And then we have obviously have the vascular layer. We have the iris, okay, ciliary body, and the cornea, which is actually back here, okay? And then we have the retina, and that's actually where the images are processed as they come into the eye. Now, here's the big thing. Within the eye, though, we also have these accessory structures. Okay, we have the obviously superior and inferior rectus muscles and the medial and lateral rectus muscles as well. So very often, this is common. We see this quite a bit. If you have someone, so this bone, right, that the eye sits in is called the orbit. And if you have a fracture in the orbit, you can actually kind of entrap one of those muscles. It can get stuck actually between the fracture fragments, and that's called entrapment, right? So it's called basically called entrapment of the rectus. So if somebody has entrapment of the rectus, what we typically see with this is that they don't have the ability to look in the direction opposite the muscle that's entrapped. For example, if I get hit in the face with a baseball, okay, and I have an orbital blood fracture, right? And my inferior rectus is entrapped. If you tell me to look up, what you'll see is that my right eye will go up, my left eye will not, because my rectus is entrapped inside the bone. Okay, so fun things to look forward to later. Okay. Obviously, then as another part of our accessory organs, we have our tear ducts here that obviously help moisten the eye and wash away debris. Okay. the ear, and this picture got superimposed and I couldn't get it off. Sorry about that. But anyway, we'll talk through it. You guys, I'm so bad with technology, it's actually helpful. I embarrass myself. Anyway, so the ear itself has three divisions, right? The outer or external middle ear and then the inner ear. Okay, so obviously we have our tragus, our pinna, right? The anatomy of the outer ear. And you do often see sometimes with really bad ear infections that the external auditory meatus, so the hole, that goes into your ear, actually can close off almost completely. If anyone's ever seen a really bad ear infection or had one, it's pretty horrible. You can actually close off almost entirely, right? Okay, so then we have the middle ear. So then we have the three bones, okay, that help us actually conduct sound: the malleus, tragus, and the stapes, right? And they live in the middle ear. And obviously, sound travels through the auditory canal, bounces off the round window and the eardrum, and actually, that is actually how we process that sound, right? And you can actually see here branches, obviously, of the vestibular and cochlear nerves. The inner ear is actually extremely important in regulating balance. And one structure here that you guys often see, well, it's kind of covered up by the picture, but we'll talk about it anyway before we move on to the ear. The Eustachian tube. So oftentimes people that get viral infections, and or if you've ever traveled on an airplane, I don't think that I can still hear out of my left ear right now, but you'll get a little bit of Eustachian tube dysfunction, often with any viral infection and or traveling on a plane, right? And you'll feel like your ears need to pop. Right, often what's happening there is that you actually have, your eustachian tube is actually not adequately, essentially opening and essentially kind of moving, kind of regulating pressure, right? So, last but not least, the inner ear. Okay, so we have these organs within the inner ear. Okay, obviously we have the cochlea, right? And we have the utricle and the saccule, okay? Utricle and saccule here. Okay, now here's the deal. Inside of the utricle and saccule live these otoliths, right? And the otoliths are like these little tiny rocks, okay? And they live inside of this gelatinous base, right? Called the otolithic membrane. Now, for many different reasons, sometimes due to trauma, like if someone takes a blow to the head, one of these otoliths can actually become dislodged from the otolithic membrane, and it can actually make its way out of the saccule and into the semicircular canal. When that happens, people get dizzy as can be. Okay, people develop symptoms of what's called benign paroxysmal positional vertigo, or BPPV. Okay, now you can see though that as if this system is functioning properly, it's actually meant to help us maintain balance as head position is changed. Right, so if you see here, this gentleman is standing upright. Okay, and those otoliths are actually also kind of just sitting within that gel, but when he bends over, the gel shifts downward. The otoliths shift downward with it, right, and help him regulate his balance. With a difference in head position. So, excuse me. There are times though, right, where because of age, actually, these otoliths actually can begin to crack and break. And a tiny piece of otolith will actually break off into the semicircular canal in individuals who are a little older, right? And they can develop vertigo that way as well. All right, terms. Okay. A lot of this is self-explanatory, right? So cerebello, cerebrum, right? Cerebello, cerebro, duro, and that's one structure we didn't cover, which is actually the covering around the spinal cord. So if somebody has, for example, and this happens a lot, if somebody has a subdural hematoma, what do you think that means? Subdural. Yeah. Absolutely. Absolutely. And so, generally speaking, if you ever have someone, right, that has that, I'll actually show you what that looks like over here. So we have this, for example, here's a skull. Okay, we have this little opening here in the face. Good, I'm in that. Okay. There it is. And then we have the brain obviously floating inside the skull. Obviously, kind of submerged in spinal fluid. Okay, but for example, let's say that someone maybe they get in a car accident, or they fall from a height and they hit their head directly on an object. Okay, they develop gross neurological changes right away, and they start to develop a hematoma underneath the dura. Right. So what happens is right here underneath, okay, the skull begins to essentially fill with blood. Okay. Now what that actually does is it actually causes what we call a midline shift. Okay, of the brain. Okay, so ultimately, instead of being directly in the center, the brain will then be shifted over this way. Okay, and so we have this midline shift that takes place due to the increased pressure on the inside of the skull. And you guys will see that like, if you ever work in maybe you're working in an ED or in like an urgent setting, you'll often see like on CT that it'll look like the brain is like shifted to the left inside of the skull. It's called a midline shift. Okay, that's indicative of a subdural hematoma that will have to be evacuated surgically. Because they'll go in, they'll shave your head, they'll cut your skull open, do a craniotomy, and then they'll actually kind of evacuate the hematoma with suction. Pretty cool stuff. So, okay. Obviously, encephalo means brain, right? So if someone has, and this is kind of a buzz term that is kind of going around. I shouldn't say that, but this is a term that's going around called chronic traumatic encephalopathy. Okay, who can tell me by using the word parts what that means? Chronic traumatic encephalopathy.
Head injuries.
Okay. Yeah, so it's CT, right? So chronic, which means kind of happening over a long period of time, traumatic, pertaining to trauma, and then encephalopathy, right? A brain disease. So CTE, obviously, as you guys know, is something that currently, unless the science has changed, has generally only been diagnosed posthumously after someone passes away. But there's definitely still some debate within the scientific community regarding the kind of the deposition of tau protein and whether or not that's actually due to normal brain change over time and dementia-related changes and/or due to trauma itself. So, anyway, okay, big one, myelo. Okay, this is actually pertaining to the spinal cord. So that's the word for spinal cord. So often you'll hear a term called myelopathy. Okay, what do we think myelopathy means? Bingo. Okay. Now here's the deal. I know that it kind of seems kind of like an arbitrary term, like who cares? But when you guys are learning how to take a look at a patient, when you're learning how to examine someone, okay, people who have myelopathic symptoms will have reflexes that are abnormal generally on both sides. Okay. Generally, it's going to be bilateral. Okay. What's an example of that? So you may have someone that maybe they will. Yeah, kind of a common one actually is there's a reflex that you'll learn called Hawkman reflex. Right, so they actually have them kind of relax their hand and you kind of take the tip of their finger and you flick it. If someone is myelopathic, you'll see them do this. Okay, and so if someone's myelopathic, it means that maybe they have like a big disc herniation that's pressing on the spinal cord, and/or maybe there's some sort of central, maybe kind of some sort of encephalopathy or brain. Or pathology at the brain that's actually causing that abnormal reflex. Okay, another one, okay, radiculo, pertaining to a nerve root. You're going to see the term radiculopathy a lot. Okay, radicular, pertaining to the nerve root. Okay, esthesio, which means sensation. So someone who comes in and complains of numbness and tingling is said to have dysesthesias, meaning that they have abnormal sensations. Okay, they have dysesthesias. Geez. Okay, so obviously we have terms like mento, freno, or psycho, which means mind. Okay, so Obviously, one way that we, a term that I know we're all familiar with, okay, if someone is schizophrenic, right, we definitely kind of see that word right there, schizophrenic, right? Someone who has a psychotic break and/or an episode of psychosis, right? We know that, right? And then obviously, mono meaning one, phasal meaning speech. Someone who has obviously aphasia. If someone has aphasia after a stroke, what does that mean? They have aphasia or dysphagia. Let's go with aphasia first. Aphasia. Yeah, not able to speak. What about dysphagia?
Trouble speech, like
Yeah.
saying,
Absolutely. And or abnormal, so they might be slurring words, right? So, yeah, excellent. Okay. All right. So polio, actually, this is actually both a term for a condition, but also pertaining to the gray matter of the spinal cord. Okay. And then another big one, right? Iatro. So if you guys look, oftentimes, if you were to ever look at a medical malpractice claim, you'll see the term you'll see the term used, iatrogenic. Okay, iatrogenic means kind of originating from the physician. Okay, so iatro means physician, right? Okay, a couple of prefixes. Pre meaning before, tetra meaning four. Obviously, we know bi is two, right? So tri is three. Okay, so obviously some suffixes here. Iatrist, okay, urologist is a specialist. Excuse me. Iatry is a specialty, and or treatment. So we see terms like physiatry, psychiatry, okay, pertaining to a specialty of the mind, right? And then we have paresis, which means slight paralysis. So a stroke patient who has hemiparesis, if someone has hemiparesis, if they have left-sided hemiparesis, what does that mean? Hemi meaning what? Yeah. So what do we think that means just in plain English? Hemiparesis. The left half is slightly paralyzed, most likely due to an infarct on the right side of the brain, usually. Okay. Yay, special senses. Lots of terms here, guys. Okay. Blepharo, okay, eyelid. Okay, conjunctiva. If someone has conjunctivitis, they have inflammation of the conjunctiva of the eye. Okay, so right around the lid, near the eyelashes. Okay. Ultimately, and that's pretty cool. So that obviously comes in both viral and bacterial varieties, right? So generally, more bacterial is going to be green and goopy. They're going to have a lot of discharge from the tear duct, whereas viral is generally kind of just more crusty in the morning and nasty. Generally develops after a viral infection of some sort, typically respiratory, right? So obviously, lacrimo, okay, pertaining to tear duct, oculo, okay, or opto or ophthalmo. Okay, retino, pertaining to the retina, sclera, okay, audio or akuo, right? Oro or odo ear. If you're using an otoscope, everybody's seen an otoscope. We look inside of someone's ear with that, right? Labyrintho, mastoido, crazy, right? So when we're dealing with people that have really, really bad sinusitis, which is what sinusitis? Okay, sinus infection, basically, yeah, and or inflammation of sinuses. Generally, if that goes untreated, they can develop a complication known as mastoiditis, actually, where the as the bacteria continues to produce toxins, and it's not been treated, they can actually develop progressively worsening pain behind the ear, and that can actually, if left untreated, result in necrosis of the bone, which is obviously very, very bad. It's a medical emergency, so mastoiditis can be a complication of sinus infections. Okay. All right. Few more words here. Cryo. Okay. Diplo, double. So if someone has diplopia, what do we think diplopia is? Diplopia. double vision, okay? Someone has diplopia, they have double vision, right? Okay. Someone has photo meaning what? They're photophobic. Okay, they're sensitive to light. If anybody's ever, had a concussion or a mild traumatic brain injury, if any of you have ever experienced photophobia, you know that is zero fun, sir. Okay. All right. Other words to know here for you as well. I'll tell you what, guys, we're about to get into my favorite system. Kind of, it is, but let's take a break. Let's take we can do 10. Let's do 10 minutes. Okay, kind of stretch your legs, do what you need to do. And then yeah, we'll come back and do our last lecture for this class. Okay, so 10 minutes.
Yeah, so it works better than we have account rather than like a single account. It's then it's always like, it'll tell you sharing outside the whatever. Yeah, the shared drives thing, and you shared drive. And then once you go in there, it's just like you're sharing a document, the share permissions, it's the same deal. So you just send the link off. Yeah. Yep. Yep. All right. Yeah. If you run into issues with it or whatever, just shoot me a text or call. Yeah, good luck. Nice. One round, we're rubbing up this thing off.
Everybody look. That's okay. I told Izzy to take pictures.
Oh, is he in that? Nice.
Yeah,
That's
there's like
kinda cool.
3 people.
Cool.
Izzy, Izzy, I told her we should give one of the textures to join us.
You know what I mean? I do it again. Do it again.
Oh, what? I don't know about.
What do you think about this?
So once semester left, and then I took the class and I'm
Well, yeah.
doing this nursing stuff, so. Yeah.
Was that a specific area? Like, probably.
I feel like I've been kind of robbed of my college experience in that aspect for clinicals. So I don't really know what I want to do yet because I haven't really had enough opportunity to figure that out. I really like cardiac, I like working with, the heart, but also like, psych. mental health and that kind of side of things. So I know kind of what I don't want to do right now, but I don't really know what I want to do. So I got narrowed down a little bit. I currently work as a CNA in a hospice house. And that's a very rewarding experience, but probably not something that I want to do for my career. So it's a different.
Why?
I don't know, but I had to go.
That would be rough.
No,
That's so.
I had to.
Definitely not for everyone. So, yeah, but I think it's pretty cool to see the feedback that you get from the families and the patients and. Yeah, it's really awesome. They're so thankful. What was it, like a couple, I think a year ago, I was like with a patient and they go nurse to her, like, hey, can you go sit with her and make sure she's doing okay?
Yeah,
I sat with her while she was sleeping, I held her hand, and as I was holding her hand, she died. And so it was kind of a crazy experience. It was really cool. Yeah.
Bird weather really. People that work on those settings all the time. That actually have really interesting stories. Because people are this is the vast transition of what happened. It's very new years. People that.
Well, and it's really interesting because as you die, your brain is, essentially growing. And so, like, the way that you act or that you function as in the dying process is so different. And so you're seeing like hallucinations and you're like saying things that you wouldn't normally inherently say. These people have like hallucinations back from when they were kids, or back from when they worked. And so it's kind of cool to like, oh, I gotta work on the farm today or the field, and you're like, oh, we're at a hospice house. We gotta reorient them, but it's, I guess that's just with, working with older people. It's kind of cool to see how that process works.
I'm a judge, so I have no idea what to do it.
Yeah, I'd say, it's good that I don't have that family or friend connection with these people, because it would definitely so difficult because you develop relationships with these patients while they stay. So we had this lady that was in our facility for over a year, and then she passed, and we were all really upset because she had just made it to 100, but it was cool. So yeah, kind of what you sign up for. So I'm excited to work in nursing, and even though COVID's been crazy, it hasn't fully deterred me. So should be fun. Should be interesting. I think all medical careers are very sought after now, just in the wake of the pandemic, and realize how important healthcare is and overall health. So, especially seeing family members pass away, and of not just COVID but other diseases too. It's kind of crazy to just realize how important that part of our life is. Being healthy.
Absolutely.
Yeah.
And just a
Yeah, exactly.
But she is a redhead. She is a redhead. She is not strawberry blonde in that photo at all. Stop that.
Oh, she claims she's struggling with it, but she's struggling. It really makes sense. Strawberries not.
It's the same.
The same as a red tint blonde.
So mad. She was so mad.
I think we're at about the 10-minute mark, maybe, unless I'm mistaken. So we'll go ahead and get rolling with Last lecture, guys. So. Bless you. Yay. Actually, sure.
What?
I'm so cute. No. There it is.
All right, can you guys see my screen on Zoom?
Yes.
Wonderful. Okay, and you guys can hear me okay? We're good, sound wise?
Yep.
Awesome sauce. Okay. All right, guys. The last one. This is actually, I mean, this class obviously has been brand new for me, but this is I like that we're going to finish with this because I think it's going to be very, I don't know, maybe kind of a fun way, at least for me, maybe, to kind of end the lecture portion of the class. All right, so kind of using some terms here, right? Who can tell me? So, and this is maybe assumes a little bit of knowledge in anatomy. Who can tell me though what that means? We're going to start off. So, transsphenoidal hypophyseectomy. The big word. All made transsphenoidal. So remember how we golly. Wow. So remember how we talked about that sometimes people will describe approaches, right? Surgical approaches, via anatomy is like, so we talked about a transurethral prostatectomy a couple weeks ago, right? So taking a transurethral approach to the prostate. So transsphenoidal hypophyseectomy. Any thoughts? It's a fun one.
The approach is to the sphenoid bone. Go.
Yeah. Okay. So remember, yeah, Josh.
Removing.
Okay. Yeah. So remember we talked about there's actually another name for the pituitary. What is it? I heard you say it's right. No, maybe not. Okay. What was it called? So we actually have a vascular network. Yes, hypophysis. Yeah. So a transsphenoidal hypophyseectomy. So we're actually taking a transsphenoidal approach, right? Making a cut into the bone, right? And removing the pituitary. Holy cow. There it is.
Why would you need to do that?
It's a great question. So I didn't make this lecture. I've actually, believe it or not, I am not familiar with that kind of surgical procedure at all. It could exist. I'm just not familiar with it. All right, here we go. Oh man. All right, so the musculoskeletal system, right? So obviously made up of muscles, bones, ligaments, tendons, all the things. Okay, so we have the axial skeleton, right, which is essentially the skull, the thorax, the spine, okay, rib cage. Then we have the appendicular skeleton. Okay, we have the arms, okay, arms, legs, pelvic bones, innominate bones, all right, as you can see here. Okay, obviously, okay, we have generally over 200 bones, about 206 in the human body. We actually have these, sometimes people can actually have these accessory bones that develop. So there are things like an accessory navicular. People can develop, so it's essentially a bony projection off of a bone in the foot called the navicular, right? And there are other things too, like, often on a knee x-ray, you'll see this little tiny piece of bone, this little tiny bony, or kind of little circle. and that's actually called a fibella. That's actually a sesamoid that actually we have when we're young. Did you know, by the way, that little babies, the next time you're holding an infant or like a newborn, go and feel, like actually go and feel their knee. They don't have kneecaps. Over time, as they learn to crawl, right? Those, you guys are looking at me like I've lost my mind, but I'm serious. I'm completely serious. When they crawl, actually, those sesamoid bones develop because of friction, right? And they'll actually develop that. That patella will become kind of more ossified over time, and you'll actually be able to feel it. Okay. So obviously, okay, arthro is the term for joint. So we have all these articulations. It's another term for articulation. So I have an articulation, obviously, between my radius ulna and my uterus. Okay, so if I ask you, where does the radius articulate with the humerus? Okay, there's going to be a specific bony landmark where that radial head touches the humerus, right? And I was going to ask the question, but I'm not going to ask the question. Okay, all right. So clearly, a lot of our joints, our articular surfaces are covered in cartilage. What does cartilage do? You can tell me what it does. What's its function? Okay, so it cuts down on friction. Okay, yeah. What else? What else does it do? Okay, provides support. Yeah, and we see that definitely in places like the shoulder and knee, where it actually deepens the socket and increases the contact area of one bony surface with another. Right. So obviously we have things like the like the menisci and the knee, the glenoid labrum and the shoulder, and then obviously the acetabular labrum in the hip. And then we have ligaments. What's a common ligament that all of you have kind of heard of and or maybe know a little bit about? Obviously ligaments are common. They connect bone to bone. What's a big one that all of us kind of know of? It's kind of a general term that's kind of worked its way into our general vocabulary. ACL, okay? We'll talk about that in a little bit. Super fun. Okay. All right. Clearly, okay, the skeletal system serves to essentially provide a framework for muscle and organ attachment. Has its support of body weight or movement, right? But the other thing that it does, obviously, is also aids in hematopoiesis. What's hematopoiesis? So if I have poiesis, what do I have? What is that? Formation. Okay. Hematopoiesis, which is formation of blood cells. It's right there on the slide. Okay, cool. By the way, Joseph, I will never forget your face when last week when I said that I had an umbilical hernia. You were like, I will never forget that as long as I live. That's probably gonna be the last thing I see before I die. That was a joke. I don't mean that like I'm probably just gonna see Joseph's face. Total joke, Joseph. Just joking. Okay. Okay, so obviously, all right, bones actually also obviously aid in mineral storage, obviously, storage of calcium. Okay, osteoclasts help us break down bone, osteoblasts help us build bone. Okay, and bones are actually obviously living tissue. They actually also help us obviously protect vital organs. Okay. All right, friends, here we go. So the bone itself actually has different regions. Okay, so generally speaking, we have the diaphysis, which is the middle or shaft of the bone, right? Then we have the epiphysis, which essentially is the end of the bone. Okay, usually we have the epiphysis and the diaphysis separated by a growth plate. Okay, now here's a question for you. Generally speaking, are people that are skeletally mature, so me and you, are our growth plates open or closed? They're closed. Absolutely. Okay. What about a 5-year-old or a 6-year-old? Will their growth plates be open or closed? Open. Okay. Now here's the deal. What happens? Okay. What type of fracture? Well, I'm going to ask it anyway. What type of fracture do we typically think of that typically extends into a growth plate? Right. What's that called? Anybody know the name for that? And depending on the type of fracture, can affect growth plate function. Okay, yeah, so it's, yeah, but there's also kind of a broader kind of like classification called the Salter-Harris classification system. So anyway, but back to this, right? So obviously, okay, within the bone, obviously, we have different types of marrow. Okay, we have red bone marrow, which is where the red blood cells are actually made, and then we have yellow bone marrow, which actually is where we store fat in the bone. Okay. Ooh, and fun fact: if you guys look at enough X-rays, actually, over the course of your career, you're going to see that that there are spots essentially where this yellow bone marrow actually makes these little tiny cellular projections, and actually they kind of leaves them in the bone itself, right? And so you'll see things like, you'll see like enchondromas, and you'll see other types of like fatty types of kind of like little tumors or buildup in the bone. Generally, these are benign; they're not cancer, right? But you'll see things sometimes that look funny, almost kind of like popcorn, or like other little circles, like just sitting right in the middle of the bone. Generally speaking, that's due to essentially the kind of the remnant of yellow bone marrow fat storage. Okay, muscles. Okay, obviously muscles are capable of contracting. Okay, so obviously they shorten and they lengthen. But we have two different types of contractions that take place, right? If I have a muscle contraction where I am shortening the muscle, what's that called? What type of contraction is that? If I'm shortening the muscle, it's called eccentric. What if I'm lengthening the muscle? Eccentric. Okay. Okay. So tendons obviously attach muscles to bone. Okay, so ligament, bone to bone, tendon, muscle to bone. All right. We have three types of muscle tissue. So we have skeletal muscle, which is striated. You can kind of see the stripes in it, right? It's under voluntary control, which means I can decide to move it, and I decide to move on or move on, right? Smooth muscle, okay, which is under involuntary control, regulated by the autonomic nervous system, okay, and then my cardiac muscle, which is striated and under involuntary control. All right, combining terms and forms for the musculoskeletal system. Okay, osteo, bone. Okay, osteomalacia. Okay, softening of bone or rickets. We'll see a picture of that in a minute. Okay, okay. So we know that osteomalacia, generally speaking, right, and I think we talked about this early on, where usually we see the term malacia or the suffix malacia meaning softening, and we generally think of that as being pathologic, right? So if I have osteomalacia, I have softening of the bone. Who knows, or who can tell me if you're, let's say for example that you're doing a surgery on a patient, okay, and let's say that maybe you're doing an ACL reconstruction and or some other type of surgery, and that patient has osteomalacia. Okay, what do we think that might make them more prone to actually during the course of the procedure? If the bones are soft, what do we think might happen maybe a little bit more easily? Might fracture. Yeah. I don't know if he has a slide of a periprosthetic fracture on here or not, but maybe we'll get to see one. Okay. So myodenia, okay, muscle pain. Okay, I'm sure all of you that work out and or all of you that were maybe like, I'm sure you guys on your training trip before everybody got sick. Sorry, that was, anyway. On your training trip before everybody got sick. All of you guys probably had, and I know Mitchell's had it, right? You guys have all had DOMS, okay, delayed onset muscle soreness, right? You have to practice and you're like, I feel great. And then 2 days later, you're like, oh my God, I can't move, right? You're sore everywhere. It hurts to just like even sit up straight or walk, right? So everybody's been there. I do that. That happens to me after I walk to the mailbox. And I'm like, oh God. Anyway, kidding. Okay. I'm trying to inject some humor because I'm trying to, this joke. It's a joke. Okay. All right. Okay. Leomo, right? Smooth muscle, rhabdomyolysis, skeletal muscle. However, right, there's also a term, you might want to write this down, but just fun. Rhabdomyolysis. Okay. Myolysis. Okay. What is myolysis? Lysis means a breaking down of. Great. Yeah, breaking down a muscle. Tell me more, Yash. Yeah, you're absolutely right, Sarah. Okay, but rhabdo. So if I have rhabdomyolysis, what do you think that is, Josh?
So basically, how it occurs is, and common in like the strength endurance sports, like triathlon, swimming, or like CrossFit, where people do such high repetitions of exercise that like muscle tissue starts to break down. And I guess growing, right, like the number one sign of it is pretty much like urine will be like full color,
Right.
Yeah, what?
like Coke.
Yeah, it'll look very dark.
Yeah.
So obviously, so like basically what happens is with rhabdomyolysis, the muscle tissue actually breaks down and gets into the bloodstream, right? And so ultimately what we see is as that muscle tissue gets into the bloodstream, the kidneys actually have an increased ability to filter blood and get urine, right? But because of the level of protein in the urine, because of muscle breakdown, that urine, oftentimes becomes super duper dark, right? So it looks like you're, peeing like literally peeing like Pepsi. It's kind of nasty, right? So your kidney function goes down, your glomerular filtration rate, your GFR drops a little bit below normal, generally speaking, and then your liver function also goes down. So it's fun times. We deal well. It's not fun times. It's sarcasm, but
That's not healthy.
not healthy at all. Yes.
Does it have to do with their diet or like just exercise?
It's a great question. So generally it's exercise. And this is such a good question. Okay, I love this question. So ultimately, right, if you go out into a kind of an area where everybody's active, okay, let's say we were to look at a sample of 100 basic trainees, in the military, maybe the Army, Marines, whatever, right? And everybody's going out and doing their thing and running 5 miles a day. Okay, all of them, I guarantee you, will have, increased muscle breakdown. Okay, all of them will have kind of the abnormal labs of rhabdomyolysis. Okay, however, who do we know who to treat versus who not to treat? Okay, who is symptomatic versus who isn't, right? And so, yeah, you're absolutely right. This happens in places where people are generally very active and get a lot of exercise, right? And so the muscle breaks down, gets into the bloodstream, can affect kidney function. But some people tend to do well with it. Doesn't alter their kidney function or their urine color. Other people have a big problem, right? Their urine color changes completely. Maybe they don't pee as often, and they just get very, very sore. And the muscles are tender to touch, everything hurts, right? Those are people that you worry about. So, okay. All right. So cartilage. Okay. What about chondromalacia? What would chondromalacia be? Softening of the cartilage. Okay, now here's the deal. Generally speaking, when cartilage becomes soft, we develop these little divots right in the cartilage, and ultimately what happens there is cartilage begins to wear unevenly on the surface of the joint. We'll talk more about that in a minute. But that's how we get arthritis. This actually, though, is a case of rickets. Case we can see vitamin D deficiency causing the bones to bow. There are actually also other conditions that can actually mimic this. Like osteogenesis imperfecta, which is actually a genetic disorder where the collagen of the bone is actually inadequately formed. Right, so people that have osteogenesis imperfecta often will fracture bones very easily. And actually, this you can actually see here. This guy does have a little bit of a line because you can actually see a fracture line right there at the tibia. He's probably broken in the past. So yeah, it's really interesting. Okay. All right.
You know how that affects like the movement?
So generally speaking, and that's a great question. So people that have OI, generally they'll be kind of shorter stature because if they have a break or a fracture through the growth plate, it'll actually kind of shorten the bone itself. So people that have that will typically be shorter, not shorter stature people, and then there will be obviously like limping and other things that will happen because of that. So, but okay, we have arthro, okay, joint arthritis, inflammation of the joints, spondyloarthritis, okay, which is essentially, inflammation of the vertebrae. Crazy cool. So if you've never seen ankylosing spondylitis, it's crazy times. So we actually get these bridging syndesmophytes actually at the vertebrae. This is actually what happens. So we get these. Here's a vertebrae, right? So here's one. Okay, here's another. All right. So then what happens is here's my disc in between. What happens though with ankylosing spondylitis, we get these bridging syndesmophytes that actually will actually kind of connect one vertebrae to another, right? And the segment itself actually becomes involved. This can actually progress to such an extent where we actually, there's a condition that we developed known as DISH, right? Where we actually can fuse bones together completely, both at the front and the back, so anteriorly and posteriorly. And these individuals have absolutely zero movement, right? So that's called DISH. But if you see like these little bridging syndesmophytes, and I'll actually start off. I'll start off looking like this. Okay, just like so. But ultimately, they have this affinity to want to grow together over time. So look at these bridging syndesmophytes, and it's crazy. I mean, once you see it, you'll never forget. Okay. Okay, vertebra, or vertebral, right? Vertebral column, myelo. Okay, means bone marrow or spinal cord. Okay, so multiple myeloma. People that have multiple myeloma, this is generally a cancer of white blood cells in the bone marrow. All right, arthritis. This was like my home for 2 years. So let's talk about some arthritis. So we have, well, generally speaking, we actually have there's more than just these two types. So we have osteoarthritis. This is actually the most common type of arthritis. And so it can happen, obviously, in older individuals, or we're seeing this actually more often in younger people. So I had people that I've seen in my practice. I had a patient of mine years ago, okay? And this young lady tore her ACL when she was probably 13. She's 13, tore her ACL. By the time she was 20, she had arthritis. Okay, so she had advanced venous arthritis at the age of 20. And had to stop playing volleyball. So, okay. So, generally, the vast majority of osteoarthritis, though, you'll notice that particularly if you talk to people that have arthritis, the vast majority of them actually have had a previous injury to that joint before, whether it's a meniscal tear or an ACL injury, they've had a previous injury. Okay. Rheumatoid arthritis. Okay, this is actually an autoimmune problem. Okay, this is actually where the body actually kind of attacks itself and actually wears away at the joint tissue, right? And this actually has this has many different forms. Here's the deal. One of the giveaways, clinically, one of the routine giveaways for this type of a problem is if you're talking to someone and they tell you, yeah, I've had this problem in multiple joints. Okay, generally starting maybe in the small joints of the fingers, right? It's like, yeah, I have these aches and pains everywhere. Okay, and that's kind of a differentiating factor between that and osteoarthritis, where people will often just have symptoms maybe in one joint. They come in and they say, I hurt here, as opposed to saying, I hurt here and here and here, right? So that's kind of a differentiating factor. You can actually even see this in younger people. So we even have what's known as JRA, or juvenile rheumatoid arthritis as well. So we have gout, right? There's actually also gouty arthritis, which is due to the deposition of uric acid crystals. Often, though, more often than not, this is actually pseudo gout and not true gout. And then we actually have things like psoriatic arthritis as well. Okay, so we talked about, and here's a perfect example. Guys on Zoom, are you still good? We're good with sound, and you guys can see. Okay. So here's an example of chondromalacia. We only have 15 minutes. Here's an example of chondromalacia. Right here. Okay, you see that cartilage kind of thinning and softening. Well, what happens there is that the surface of bone starts to break down. Okay. So hopefully we'll get to see a picture. Okay, finally. Here's an X-ray. All right. So you can see here, obviously, what we're looking for is symmetry in joint spaces. Okay, so medial, lateral. Okay. Ultimately, you can see just a little bit of asymmetry there between the medial and the lateral side. Okay, but here's where it really shows. Right over here. Okay. Look at the lateral side. Okay. Here's the medial side, actually completely narrowed down on the inside. And what happens is over time, as this continues to narrow down, okay, the bone starts to wear away. And ultimately, what happens is the bone wears away. The joint actually gaps open the opposite direction. right? And these people develop essentially these deformities, right? So this person has a various deformity of this knee. All right, so rheumatoid. Okay, here's an example, so we can see kind of that inflamed synovium, right? And narrowing of the joint spaces. Okay, here's an amazing picture of rheumatoid arthritis. We talked about kind of some of the differentiating clinical features of this disease, right? Typically goes from the small joints to the hand first, generally speaking, right? And we can see kind of how this looks, obviously very like, degenerated, but also kind of like little knobby projections off the bone. So we can see kind of the main difference between RA and regular osteoarthritis. Okay. Gout. So obviously uric acid crystals can actually sometimes get deposited within joint spaces, okay, and can cause gout. So here's an example of gout. Okay, you can actually see Josh. Ultimately, the spacing here is actually pretty symmetric. Okay, look at over here. We got good spacing, good spacing, good spacing. Okay, lack of spacing, obviously some uric acid crystals out here, right? And so that's gout. All right, osteoporosis. Obviously, this is a decrease in the density of bones. All right, definitely more common after menopause, obviously in females. We generally try to prevent this by supplementation of vitamin D and calcium. Although there are other medications that once someone becomes osteopenic, meaning they have a kind of a fewer number of osteoclasts that are there, right, to kind of rebuild bone, right? There's medications that can be given that are known by the kind of their class, bisphosphonates. But then we also have other types of injections, like reclast and other things that can be given to people that have osteopenia or osteoporosis. Okay, you can see obviously on the left, kind of a normal cross section of bone with some pretty kind of symmetrical lamellae there, and then obviously on the right, very much thin. Okay, very much thin on the right, much more brittle, obviously, and prone to fracture. Arthroscopy, okay, yay fun. Okay, so we're looking inside of a joint, obviously with a scope. This is actually a hip, so you can actually see right here's actually the acetabular. So here's the hip socket. And you can see over here, here's the femoral head, the neck, right? And this is actually what it looks like on the inside, right? So it's covered in cartilage. So when you stick a scope inside of somebody and you're looking around, you're going to see this white glossy stuff everywhere. Well, that's the cartilage. Okay. Now, ultimately, when somebody develops, osteoarthritis, generally this cartilage will begin to wear away. You can see how it's kind of roughened here. Okay. The cartilage will begin to wear down. You can see maybe a little bit of subchondral bone right there. So in the event of arthritis, we start to see wearing away of that cartilage. Okay, dude, this is like my jam. I did this for like 2 years. It was the best. Well, yeah, it was pretty cool. Okay, arthroplasty. This is surgical reconstruction of a joint. Okay, crazy times. So we can actually put metal and plastic in joints to actually resurface them, right, and mimic the cartilage inside of a joint. So generally, okay, you can see how what we're doing is we're essentially making bone cuts, obviously, around the femoral head and the tibia, right, to kind of flatten things out and create a nice base for this prosthesis. Most of these, and this actually is actually a press that it's not even cemented, but yeah, ultimately, usually they'll put these in with cement, but they've actually developed other models over time that you actually just kind of just tap into the joint, and then they actually just kind of grow into the bone. But this type actually has kind of more of a tendency to loosen over time. So here's an X-ray, right? These are actually cemented in. You can see, obviously, here's the femoral component, tibial component, okay? And they actually grow right into the bone. Sometimes they'll put like cement now. You'll see like little fluff around here sometimes. So super fun. There's another knee. Okay. All right. There's a hip. Hey, you guys know which joint always tells the truth? Yep, hips don't lie. Anyway, that's enough of that. I was holding on to that one leg for weeks. For weeks, I was holding on. Okay. All right, so hips always tell the truth. Okay, here we go. Here's the hip, right? So we can obviously see that's that hip component. So in a hip replacement, we actually completely and totally cut off femoral neck and then we reattach them, obviously, through metal and plastic. All righty then. So, gosh. Okay, here's another. So this actually represents a little bit of a complication with the surgery. So the surgeon, when they were actually doing this hip replacement, actually re-stocking this hip a little bit too far. And the problem here is that with it being so close to the pelvic wall, over time this can actually subside right to the pelvic wall, and they have like literally a metal cup like next to their bladder. So you have to go in and fix that. It's a problem. Okay. Oh, we already did this. Silly Josh. All right, guys. Holy cow, it's 12:01. Yeah.
So, when you do like a hip replacement or
Yeah.
a knee replacement or anything like that, it doesn't cover cartilage again. How does that, does that change things?
It's a great question. So generally speaking, right, on hip replacement, when the acetabular is being cleaned out, we take the cartilage, right? So the cartilage, the problem with arthritis is the cartilage has actually been so badly kind of being embedded in the joint that it's no longer doing its job, right? And so ultimately to fix that, we ream everything out to where we get it kind of down to bleeding bone. We take the cup, we tap it in, right? And a lot of these cups actually, if you look at the back of them, so these acetabular cups actually have little ridges on the back. So what that actually does is the bone actually grows into that cup. Right? And then we have a kind of a plastic binder that goes inside the cup. And we put the stem in, and we have a little ceramic pink ball made in France. I guess I gotta give them something to do, right? Anyway, no offense to French people. It's but yeah. So ultimately, because the cartilage is actually eroded so much, generally speaking, that's essentially how people kind of get through life, right? After these replacements. One of the biggest risks though with this type of surgery is if you do this to someone that's really, really young, like 30s, 40s, the chances of them actually having gone and have what's called a revision done are a lot higher. Right? So if I'm 45 and I get a hip replaced, right? The chances of me having to go and have a second one done are a lot higher because the longevity of these implants generally lasts about 15, 20 years. We don't really know yet. That's generally what we're seeing, 15, 20 years or maybe a little more. So yeah, it's super fun. So the final, guys, on Tuesday, we're gonna give you guys options. You can actually come into class and sit here in class and take it and be done. Or if you want to do it, obviously from your room or whatever, asynchronously, you can do that too, okay? So the timeline for that is gonna be a little tighter. It will open up on Tuesday morning and it will actually close by about midnight on Tuesday at 11:59. So if you want to just come in, knock out the final and be done, you're welcome to do that. I hope you guys have enjoyed this class. I know it's been super compressed because of the J term, but I hope it's been fun. I've had a lot of fun teaching it, although it's been kind of very rushed, but hopefully it's been a little bit more than just learning terms. So I hope. But I do have some jokes sometimes. It happens. It happens. All right. Guys, have a good day, okay? I will see you not next time. Or Tuesday if you want to come take the final. Guys, thanks so much. Do you guys have any questions? Zoom folks?
Thank you.
Yeah, of course. If you guys need anything, let me know.
Thank you.
Thanks, guys.
Thank you.
Yeah.